Hi guys, welcome to your snow day makeup video. What I'm going to do is basically go through the slide presentation that we would have looked at in class, and we'll go from start to finish, move fairly quickly through a lot of it because a lot of it we've already covered, and highlight some of it, some of the more confusing stuff, go over that pretty slowly. Okay, so let's get started here. So, the heart's a double pump. I already talked about that in another video. And we did look at this schematic in a video. And I think I made my point about this that um, basically the right and left sides of the heart are separate pumps. However, the two circuits, or the systemic and the pulmonary circuits, are connected. So the two pumps work in series, and this is a closed system. And because of that, we have some dynamics going on with blood flow and the pump mechanics. This next slide is a really nice synopsis of blood flow through the heart and exactly what's going on during that process. Okay, so it takes you through a cardiac cycle, starts you on the right side of the heart, which is arbitrary, but we tend to do that. We tend to start on the right side of the heart. Okay, so make sure you know this process and take a look at that. That's a beautiful ordering question. This picture here, you can print this up and basically use it for your own study guide. That's why I added it in here. This is from your textbook. And this picture is taking a look at the valves and what's happening during different parts of the cardiac cycle with the valves. And you understand, I'm pretty sure that you guys already know that closure of an AV valve, closure of the AV valves is the first heart sound, and closure of the semilunar valves is the second heart sound. So I pose this question to you: what prevents the AV valves from prolapsing into the atria during ventricular contraction? And we talked about this in class a little bit. I said that the papillary muscles actually contract first before the rest of the myocardium in the ventricles. And so that basically puts some tightness or tautness onto the chordae tendineae, and it's going to prevent the AV flaps from prolapsing into the atria during ventricular contraction. We also looked at this slide, and the question that I pose is: during what phase of the cardiac cycle is the myocardium perfused with fresh blood? We talked about the coronary arteries and the openings to the coronary arteries, which these pictures show very nicely. And then we also talked about the dicrotic notch, which is the point of, so within the aorta, when we're looking at the pressure within the aorta, the dicrotic notch is a quick increase in pressure after the ventricles contract. And what that is actually blood that hasn't made it over the arch of the aorta will back down into the semilunar valve, let's say the aortic semilunar valve, because we're talking about the left side of the heart. And that blood will actually pool within the cusps of the semilunar valve, and that blood is now available for the coronary arteries to pick up, and there's a slight suction in those arteries. And this happens during ventricular diastole. So the coronary arteries will suck up that blood during relaxation of the ventricles, and this is when the cardiac myocardium gets fed with blood. In this particular slide, we're looking at the conduction system, and so what this slide is really talking about is how it is that the cardiac myocytes are able to all contract together. So there's a coordinated activity of the heart, and it's basically because of the fact that they're connected through gap junctions, which allows ions to flow between cells, and also that there is an intrinsic conduction system. And this intrinsic conduction system is driven by non-contractile cardiac cells. These are specialized cardiac cells that have the ability to set a rhythm. Autorhythmicity means the ability to set its own rhythm. And we know that the sinoatrial node has the fastest rhythm. It's got a rhythm of 100 beats per minute. So it tends to set the pace. So here are all the particular elements of the conduction system. So we've got the SA node, which is in the upper part of the right atrium, and its intrinsic rhythm is 100 beats per minute. AV node is 40 to 50. We've got the AV bundle at 30 beats per minute, bundle branches, and then the Purkinje fibers. And we have some terminology here. So an arrhythmia is an irregular heart rate. Fibrillation is rapid and irregular or out of phase contractions. We could have atrial fibrillation, and we can also have ventricular fibrillation. Ventricular fibrillation is much more dangerous than atrial. Atrial is rather common. Atrial fibrillation can become a dangerous situation, but people usually do not die from it. And so let's see, we've got sinus rhythm. The sinus rhythm is basically the rhythm set by the SA node. And ectopic focus is any abnormal pacemaker. So if the AV node takes over as the pacemaker, that can sustain life because it can beat at around 50 beats per minute. That would be called a junctional rhythm as opposed to a sinus rhythm. But really any of the cells within the conduction system can take over as a pacemaker. And these two pictures are showing the conduction system. And I've uploaded a video on the conduction system, so I'm not going to spend too much more time on that. Now, I asked a question at the end of the video on the conduction system about the SA node. And I said that the SA node is the pacemaker of the heart. And its intrinsic rhythm is 100 beats per minute. So why is it that normal or average heart rate is around 75? What other influences or outside influences make the heart slow down? And that would be the extrinsic controls. That would be the nerves supplying the heart. We have the sympathetic nervous system and we have the parasympathetic nervous system. And actually, it's the parasympathetic nervous system, which is the brake. It puts the brakes on the SA node. It slows it down. Let's talk about that system first. That arises from the medulla oblongata. It's carried through the vagus nerve, and the neurotransmitter is acetylcholine. The receptors are called muscarinic receptors, and it decreases heart rate. It brings down the SA rhythm to about 75 beats per minute, and this is called vagal tone. So the parasympathetic system really has a little bit more influence on the heart than the sympathetic system. Now, this term chronotropic is related also to inotropic, so we have to learn about these two terms. Chrono refers to timing, and so anything that has a chronotropic effect on the heart is affecting the heart rate, changing the heart rate in some way. Okay, and inotropic refers to contractility of the heart muscle, and what contractility means is the amount of force that the heart muscle can produce. Okay, so an inotropic effect is one that changes the contractility. So the parasympathetic nervous system through the vagus nerve has a chronotropic effect, and it has a negative chronotropic effect because it decreases heart rate. Now let's look at the sympathetic nervous system. Sympathetic nervous system also arises from the medulla oblongata, carried through the cardiac nerves. The neurotransmitter is norepinephrine, and the receptors are called adrenergic receptors. And the specific one referenced in your book is the beta 1 receptor, but there are other receptors like beta 2. There's alpha receptors as well. But for now, just know about the beta 1 receptor. Sympathetic nervous system increases heart rate and increases contractility. So it has a positive chronotropic and a positive inotropic effect on the heart. All right, let's look at this picture from your textbook. And this picture is showing the two systems, the parasympathetic and the sympathetic system, and the vagus nerve and the cardiac nerves that are associated with these two systems. So in the medulla oblongata, these systems start at, there's two different centers. There's a cardioacceleratory center, which is the beginning point for the sympathetic system. And then there's a cardioinhibitory center, which is the beginning point for the parasympathetic system. And these names are actually really easy to remember. Okay, so you'll see that the vagus nerve, which is carrying the parasympathetic information, goes to both the SA node and the AV node. And the cardiac nerves, which is carrying the sympathetic nervous system information, goes both to the SA node, the AV node, and also to the cardiac myocytes, so directly to the myocardium. And this is where the sympathetic nervous system has its inotropic effect directly on the cardiac muscle cells. All right. Now I'm not going to spend a lot of time on the ECG because I've already made up a video on that. But I do want to look at a couple of ECG strips. And also I want to remind you of the programmed approach that I gave you to start out with a basic reading of ECGs. So you want to look to see if all three waves are in at least 3 cycles. Look to see if the intervals or segments are variable in length. You also want to look at the ST segment. Sometimes the ST segment is elevated or depressed. And then you want to estimate the heart rate. And one of the quickest ways to do that, and this is just an estimate, and you have to have a fairly stable rhythm to be able to use this, is that you find 2 R waves and you count how many boxes are between them. And if there's 1 box in between them, then the heart rate is 300, 2 boxes, 150, 3 boxes, 100, 4 boxes, 75, and 5 boxes in between them, 60 beats per minute there. Now, if an R wave falls in between boxes, you can make a good guesstimate. And so the ECG, the different parts of the ECG, the 3 waves, and actually the QRS complex contains 3 different waves. It contains a Q wave, an R wave, and an S wave. So that's why it's called the QRS complex. And so we look for the P wave, the complex, and the T wave. And we also look at the 3 different intervals that you learned about, the PR interval, and the ST segment, and the QT interval. Now remember that one large box is 0.2 seconds wide or long. And I went through this picture very carefully, and so you can revisit that. This picture is from your textbook, and again revisit that in your ECG video. But let's look at these now, and let's put our programmed approach to work. So if we look at this first strip, and we've got 1, 2, 3, 4, 5, 6 full cycles. So this is a good strip to look at. And we'll look at a large box here, which is 0.2 seconds long in duration. First, what we want to do is we want to make sure that each of these 6 cardiac cycles has 3 waves, and we already did this in the video, and yes, each cycle has 3 waves, or should I say a P wave, a QRS complex, and then a T wave. And then we want to estimate, actually we want to look at intervals and segments and see if they look normal, if they look similar through each of the cycles. Are they the same duration? Do they get longer? Do they get shorter? Is the ST segment pretty much baseline, or is it elevated or depressed? And then we want to estimate heart rate. So we've got, let's see, we'll go from here to here, and we've got 300, 150, 100, and then we would have 75 here. So this heart rate is somewhere between 75 and 100, maybe 86, 87. You want to do that actually in more than one segment. Maybe choose 3 and average that together. So that's that strip. Let's look down now at this strip, and we want to look to see first of all if all 3 waves are present. And we have, let's see, how many cycles here? We've got 1, 2, 3 full cycles, and we're looking for the P wave. And I do not see a P wave here. I do not see a P wave here, and I do not see a P wave here. We do have T waves, and these T waves are actually a little bit abnormal. And then to estimate the heart rate, let's take these two R waves and notice that this R wave is about the same distance from this line. So I'm just going to count how many boxes we've got here. So we've got 300, 150, 100, and then we go 75, 60. So we see that our heart rate is very, very low. And actually what's going on here is that we don't have a P wave, which means the SA node is not firing. And so it's actually the AV node is setting the pace. We have a junctional rhythm here. That's why our heart rate is so low. It's less than 60. Let's take a look at this strip. And we've got 1, 2, 3. We've got about 4 full cycles here to look at. So let's look for our waves here. So we've got a P wave, we've got the QRS complex, and then we have a T wave. We have a P wave, and then we have another P wave. So we're missing actually QRS complexes. All right, let's go to this one. There's a T wave, there's a P wave, there's another P wave. We're missing another QRS complex. This is actually a heart block. Okay, and the rhythm is not stable enough to be able to estimate, but the rhythm looks fairly low. However, remember we're missing QRS complexes here, so there's no way that we can estimate the rhythm. And then looking at this last strip, we have no recognizable waves on this strip. It is impossible to determine intervals or segments, and it is impossible to estimate the heart rate as well. And this is actually ventricular fibrillation, and this is a crisis situation. All right, in regard to the heart sounds, I want to remind you that the picture that's included in your textbook regarding auscultation of the valves is has been replaced, and so in another PowerPoint presentation, there's an alternative picture for you to use to reference the oscillatory points for the 4 valves. And so I'm not going to say anything more about heart sounds at this point. And let's go into the cardiac cycle now. A couple of terms that you need to know: systole and diastole. Systole basically means muscular contraction, diastole means relaxation. If there's no word qualifying, for example, if it doesn't say atrial systole, atrial diastole, you're going to assume that it's referring to ventricular. And we'll talk about these volumes in just a second. So when we talk about the cardiac cycle, we're looking at pressure and volume changes, and we already went over the picture that's in your textbook. We went through that in class, but I will go through it again fairly quickly. Just remember that the pressure on the right side is lower than the left because blood is being pumped not as far, and so it doesn't need as much pressure behind it. Okay, and so however the picture is showing only the left side of the heart, so just remember that. Okay, let's go through this very quickly. One cardiac cycle, and it really, it doesn't matter where we start with the cardiac cycle. This particular cardiac cycle is starting with ventricular diastole, or should I say it's starting with the T wave, and then ventricular diastole occurs, and at that point ventricles are filling. And then we have the P wave, which causes atrial contraction, and the ventricles are completely full. And so the volume at the end of ventricular filling is end diastolic volume. The atria relax. Then we have the QRS on ECG. And we've got ventricular contraction, and the ventricles empty, but they don't empty completely. So there is a little bit of blood left in the ventricles, and this is called end systolic volume. And we went over this picture again in class. This is looking at basically the pressures in the left side of the heart, so all related to the left side of the heart. And if you look all the way up top, we've got the ECG findings associated with the cardiac cycle. We've got the heart sounds. So this is all lining up, the events. so that you can see what happens in a particular order. This middle box is showing the pressures in the left atrium, the left ventricle, and in the aorta as well. This lower box here is showing the volumes, diastolic volume, the end systolic volume, and then if you subtract those two, you end up with the stroke volume. These boxes down here are showing you what's going on with the valves. And then this last box right here is showing you what's going on with the heart muscle, whether it's contracting or relaxing. And this is just a picture taken from a different book. And this was added in there so that you could use it as a study guide. So let's talk about cardiac output now. We've talked about end systolic volume and end diastolic volume, and we're going to put that to work to figure out really basically how much blood is pumped out through from each ventricle per minute. And so if we take stroke volume, which is basically end diastolic volume, and subtract end systolic volume from that, we get a stroke volume, which is 70 mils per beat here. Okay, so 120 minus 50, 70. If we take that and times it by the heart rate, we get 5.3 liters per minute, and that's our cardiac output. That's basically all of the blood in the body getting circulated through the heart in 1 minute, and that's pretty impressive. Now this can increase, cardiac output can increase 4 to 7 times depending on conditioning, and this is called cardiac reserve. So if we take the stroke volume and we divide it by the end diastolic volume, so our stroke volume was 70, our end diastolic volume was 120, we make that into a percentage, that's actually our ejection fraction. And we want our ejection fraction to be above 50. Okay, so what regulates stroke volume? And here's where I'm going to be slowing it down just a bit. So we have 3 things that regulate stroke volume. We have preload, contractility, and we have afterload. So I have to explain what that actually means. Preload is the blood returning back to the heart. So preload is that blood being carried by the superior and inferior vena cava and the pulmonary veins. Okay? And so what preload is telling us is really preload is going to determine what our end diastolic volume is going to be. And the more blood that is returning to the heart, the higher that number is going to be. And also, preload will affect the ability of the heart to contract. And the reason it does that is because of something called the length-tension relationship. So you might remember from A&P1 with skeletal muscle that there was an optimal length for a skeletal muscle to be able to develop the greatest amount of tension and force during contraction. And that was called the length-tension relationship. Well, cardiac muscle works the same way. And so if cardiac muscle is in a fully shortened state, it will be weaker. And if it's overstretched, it will be weaker as well. So there is an optimal length. And so if there's an increase in preload, if more volume of blood is coming back to the heart, then the heart wall will stretch a bit, and this will actually be an advantage to the cardiac muscle cells, putting them at a greater mechanical advantage and allowing them to contract more forcefully. Okay, and so this is called the Frank-Starling law. So as venous return increases, the ability of the heart to contract more forcefully increases, and you get a bigger stroke volume. So the second the second regulation of stroke volume is contractility. And this is a little bit different than preload. Contractility will change regardless of the length. So if you actually had an increase in venous return and an increase in contractility, the heart would be able to contract even more forcefully than just an increase in preload alone. And so the way this works at the cellular level with the cardiac muscle cells by increasing calcium influx. And calcium, if you were to review, if you can remember, calcium is what binds to troponin and allows the cross bridges to form. And so if you have an increase of calcium, then it would make sense that you would have stronger contraction. And it's a sympathetic nervous system that has this effect on the heart. And this is what is termed the inotropic effect. This is a positive inotropic effect. And as far as afterload is concerned, afterload is the amount of pressure in the pulmonary trunk and the aorta. And the pulmonary trunk is normally, the pressure is not going to be very high. It can get high. It can get higher than normal. But more often the issue is with the aorta and with peripheral pressure from peripheral resistance. And so that's the back pressure on the ventricles. And if afterload increases, this actually will decrease stroke volume. So let's take a look at some of these relationships here. Okay, so an increase in preload increases stroke volume. An increase in contractility will increase stroke volume, and an increase in afterload actually decreases stroke volume. So the factors that increase preload are going to be things like increasing venous return. And by increasing venous return, as I mentioned, you increase the stretch on the heart. You're also increasing the rate of blood flow back to the heart. And this is going to increase stroke volume. Now, if you increased heart rate, and that was it, you only increased heart rate, what would actually happen is that preload would decrease. And the reason for that is that you decrease filling time of the ventricle. So just an increase in heart rate is not going to increase stroke volume. It'll actually decrease it because it decreases filling time. Factors that increase contractility, as I mentioned, these are inotropic, and there are positive inotropic factors, and pretty much the sympathetic nervous system is the one, and any medications that would increase sympathetic effects to the heart would increase contractility. Factors that increase afterload, as I mentioned, would be an increase, anything that increases pressure in the aorta or the pulmonary trunk. Let's take a look at the effect of exercise on cardiac output. So during exercise, we all know that heart rate increases, and you can feel it in your chest when you're exercising. You also notice that your breathing rate increases, and so you're bringing in more oxygen and releasing more carbon dioxide. So we can sense those two things happening, and that's very easy. The other things that are happening is that during exercise, you're increasing the use of your skeletal muscles. Blood is actually going to be shunted to the skeletal muscles, and that extra blood has to be returned back to the heart. And so when we talk about blood vessels, we're going to look at the mechanism of how blood is returned back to the heart. But one of the mechanisms is the skeletal muscle pumping. And so you may not realize this while you're exercising, but because your heart rate is increasing, that's going to mean that blood is moving faster through the system. But also the skeletal muscles pumping will push the blood through, back to your heart faster as well. And that's a very important process. Otherwise, you'd start to swell up really quickly if your skeletal muscles were not able to increase venous return as your heart rate increases. And so this increase in venous return is increasing the preload. And there's a corresponding increase in heart rate as well. Now, if you increase preload and you increase the heart rate, then obviously stroke volume is going to increase. But what's important here is that you also get an increase in contractility because the very large increase in preload needs a stronger, more forceful contraction of the heart. And that's basically the things that are happening here. Okay, so not only do you get an increased rate of venous return, and so this is an increased volume within a particular period of time. Okay, because remember, you can't increase the amount of blood in your body. You have a certain amount of blood, and so basically what you're increasing is the rate of return. So increasing the rate of return of the blood stretches the heart muscle more from the length tension effect on the heart muscle. We get a more forceful contraction, but we're also going to get an increase in contractility because during exercise the sympathetic nervous system is ramped up. And so we get not only an increase in heart rate, we get an increase in preload or venous return, we also get an increase in contractility, and all of this increases stroke volume, which is going to increase the cardiac output. And as I mentioned, during exercise, cardiac output can increase up to 7 times, which is a huge number, and that's known as cardiac reserve. With a sustained program of exercise, the heart muscle will actually accommodate, very similar to the way skeletal muscle accommodates to exercise. And the ventricles will hypertrophy and they will become stronger. And so what that means is that you get an increase in stroke volume without even having to ramp up the sympathetic nervous system. And so ultimately that lowers the heart rate because the heart is pumping more efficiently. And that's why athletes will tend to have lower heart rates. So what if we increase the heart rate without an increase in stroke volume? And this happens with certain chemicals and with certain drugs. Now we have a lot of drugs that will mimic the the effect of the sympathetic nervous system and the parasympathetic nervous system. And those drugs, if they're mimicking the effect of the sympathetic nervous system, let's say, then they're going to increase heart rate and they're going to increase heart contractility as well. But there are certain chemicals that will actually have differing effects. And let me give you a couple of examples. Nicotine and caffeine both will increase heart rate. And initially, they can increase contractility as well. But what is shown is that very quickly, and there have been studies done on both of these chemicals, is that very quickly they convert to a negative inotropic effect. And so initially they might be positively inotropic, but then they become negatively inotropic. And what that means is that they will increase heart rate but decrease contractility. And this is actually not a good situation because what will happen is you'll end up with a fast heart rate, but you will not increase stroke volume. And that will actually decrease filling time and your heart will not be as efficient because stroke volume will go down. All right, so what this picture is this is basically a summary of what happens during exercise. And this is a really nice summary, so I would suggest that you spend some time with this. It basically summarizes everything that I just talked about. And here is the actual definitions for the chronotropic and the inotropic effects. As far as these terms, please know the definitions of them. And so we've got decreased blood calcium, increase in blood calcium. We have an increase in blood potassium and a decrease in blood potassium. And all of these have potentially dangerous effects on the heart. Okay. You may at some point have to know how to recognize these changes on the ECGs and know the changes that occur with the heart. And these are fairly simple definitions. Tachycardia is an increased heart rate. Bradycardia is a decreased heart rate. Tachycardia generally above 100. Bradycardia generally below 60. And the other term that I threw out earlier on is arrhythmia, and an arrhythmia is basically an irregular heart rate. All right, on to our final slide of the presentation. We're going to talk a little bit about congestive heart failure because it is so common. And what's going on with congestive heart failure is that usually it starts on one side of the heart and is unable to keep up with the demands of the venous return coming back to it. So the blood returning back, it's not able to pump it out fast enough or as efficiently as it needs to, And so that starts to cause some back pressure and congestion in the venous system. Okay, and the causes, there are various causes here. Your book gives four. Coronary atherosclerosis, which would be plaque buildup in the coronary arteries, which is going to decrease the amount of blood getting to the heart muscle itself, decreasing the oxygen loading to the cells, to the cardiac myocytes, decreasing their ability to contract, decreasing the amount of force that they can produce, and decreasing the stroke volume from there. High blood pressure, this is afterload, and this is obviously going to be affecting the left side of the heart. So high blood pressure will put more pressure on the left ventricle. The left ventricle is not able to overcome that pressure. Stroke volume goes lower, and then you get a backup in actually the pulmonary system from that. Multiple heart attacks is another cause, and with that you get death of the myocytes, and a condition called dilated cardiomyopathy. This is an interesting situation. This is where actually the myocardium thins out and becomes dilated and becomes less efficient. This is actually an enlarged heart. And so a thinner myocardium is not able to generate the force that it once was able to. Okay, so four causes of congestive heart failure. And to keep all this straight, it's you have to understand that the congestion in the system happens in the venous side. So think about the blood returning back to the heart. So if you have a left-sided heart failure, you're going to end up with pulmonary congestion because it's the pulmonary veins that are bringing the blood back to the left side of the heart. And with right-sided heart failure, you're going to end up with peripheral congestion because it's the superior and inferior vena cava that are bringing the systemic blood back to the right side of the heart. Okay, so the backup is in the venous system. And so you'll end up with pulmonary edema with left-sided heart failure, and then you'll end up with peripheral edema. So swelling within the legs is very, very common with that. Okay, so eventually this ends up becoming full heart failure because it is a closed system. All right, that's it for this presentation.